We'll cover the purpose of it and basically what we can do for our patients to make them comfortable while we do procedures on them or operate on them. But first, we'll go over some review questions. I'll give you a second to read this. What do we think it is? Two. All right, good. What do we think one is? What kind of fluid is that? Transitate, yep, good. And then the other ones are all some spectrum of an exudate. Let's see what y'all think of this one. Tricky, right? So there is a difference between antiplatelets and anticoagulants. What do we think this one is? 3. Yeah, 3 heparin. Right, aspirin and clopidogrel are antiplatelets. We have heparin there. What do we use the bottom two for? Not sure. No idea. All right. So those are going to be for like peripheral arterial disease. So those are like our claudication patients. Those are the two. I mean, silostazole is probably the most common one we get for that, for improving those symptoms. All right, what do y'all think of this one? This one should be the easiest. Blood pressure, right? What do they have? Or what do we suspect? Yeah, some sort of aortic dissection, right? Good. What diagnostic test would you order on this? Yeah, CT angio would be the best test. I would say probably if it was initial test I would order would be a chest x-ray. All right, so here's what we're going to talk about today, all kinds of anesthetics and how we use them. All right, so what's the ideal anesthetic? Well, we don't have the ideal anesthetic, honestly, but if we did, it would have a short latency, it wouldn't be addictive, and great penetration, it can be reversed, no low toxicity, it's stable, water soluble. Unfortunately, we don't, and obviously inexpensive is a good one too. We don't have the perfect or ideal anesthetic, but we have some that work really well. Do you ever understand the difference between analgesia and anesthesia? Like one is pain relief without loss of consciousness, the other one is loss of physical sensation with or without a loss of consciousness. So our goal is to give them just enough to achieve pain control for whatever procedure we're doing, and then we have the commonly ones that we use there and what effect they have. So if we're trying to look at like an altered level of consciousness, propofol, etomidate, your gases work really well for that. And then if we're just looking for pain control, like opioids are great. We can use, we're starting to use a lot more pain dose ketamine on patients. Then we have Toradol or ketorolac, and then just basic Tylenol. If you're looking for like an anxiolytic, that's going to be one of your benzos. If you're looking for amnesia, ketamine works great for that. And then we obviously have our muscle relaxation medications we can use. And then some of the adjuncts, like it says on there, some like dexmedetomidine is becoming a lot more common nowadays, especially on the inpatient side of the hospitals, and then ketamine. All right, so how do they work? What's their mechanism of action? So it basically, we inject these to create some sort of direct effect on to block the sodium channels and to stop the depolarization of the nerve. So the issue is normally these are weak acids, and sometimes we're doing procedures on infected tissue, and it doesn't work very well for that. And most commonly you're going to see this when we're using like some of our local anesthetics like lidocaine or bupivacaine. And because they're more acidic, it didn't work as well for like abscesses and things like that, which is something very commonly you're going to drain. And you'll notice you don't get a lot of great pain relief with that walled off infection there. So sometimes we can add a buffer to it, like we can add sodium bicarb to it and increase that pH a little bit, which can help. It can give a little bit better analgesic effect, and it'll also create a little bit less burning and pain with the injection. You'll notice on your patients, they're worried about the needle stick, a lot of them. They don't like needles. And what you realize is the lidocaine causes like a pretty significant burning when you're injecting that in them. So this can help with that as well. So we can buffer it if we need to. All right, so what do we use? So we have amides and esters. So amides are metabolized by the liver. The other one is metabolized by para-aminobenzoic acid, and it has more of an allergic effect on our patients. And we don't usually use these for injection. The esters are typically used for more topical therapies. And you'll see like ocular therapies as well, like tetracaine. We can use it if we need to numb the eye for any of the procedures we're doing. Or if we're trying to get a pressure in the eye, we'll use like tetracaine sometimes, or one of those esters. But we're typically not using those for injection. Like the most common you'll use is the lidocaine and bupivacaine. And we like to mix these because you can see on there, like one has more rapid onset, one has a slower onset, but a longer half-life. So the duration of anesthesia can be extended depending on which ones we use. A lot of times we'll mix lidocaine and bupivacaine for our procedures just to extend that effect. But we also want to have a rapid speed of action, so an onset, so that's why we use lidocaine. And lidocaine is probably the most common one we use. And it typically will last like 30 minutes to 2 hours if you're lucky. Bupivacaine will extend it out, usually double that in those patients. So it just depends on how long you're planning on doing the procedure, how long you think it's going to take, and how long you want them to tolerate this numbness or anesthesia afterwards. So you have to think about that too, because some patients, I don't know if you guys have ever had a dental procedure where your mouth's numb for like the whole day, and you're like, what the heck, and you can't talk, and you look like you're having a stroke. So you got to think about like how soon you want that to, how soon you want the pain to come back or the function to come back. And typically, we don't have a ton of allergies to these medications, but they do happen, and we'll talk about them. All right. So what does tissue inflammation do to these medications? It's number 2. The acidosis reduces the active form of the anesthetic. That's why we'll tend to buffer it depending on what type of procedure we're doing. Even when you buffer it for like an abscess, it still doesn't get a great pain relief. And you're gonna sometimes cause more pain by doing multiple injections versus just incising it and draining it. All right, so epinephrine. So a lot of times we'll use a lidocaine with epinephrine, It's a great vasoconstrictor, so it increases the duration, and it causes a slower diffusion of the medication, so we can usually use less of it if we add epinephrine. However, adding epinephrine increases the dose we can give. So if you have a larger area or a larger laceration you're trying to sew up, you got to think about possibly adding a lidocaine with epi just to increase that duration. It also decreases bleeding because you have that vasoconstrictive effect. So we typically like to use lido with epi on everything we can. Obviously, we need to worry about if they have any sort of like underlying heart conditions. So, we want to, we need to be a little bit concerned if they're tachycardic, if they have like significant hypertension, any sort of history of dysrhythmias. That should be, that's always a concern that we may want to avoid epinephrine. Well, you also need to worry about it in patients with like hyperthyroidism, that rare case of pheochromocytoma or any heart disease. We also avoid it, and there's debatable evidence now on whether we can use it on end arteries. It's becoming more common, and we think it doesn't, it doesn't cause the tissue damage that we used to worry about. But we still generally avoid it in fingers, toes, ears, nose, any sort of penis, any sort of end, anything supplied by end arteries. We still tend to avoid it, although sometimes we can use it. But for this purpose, it's just, better safe than sorry. We'll avoid it.
So if we wanted to get increased duration of action still, what we were doing in the visual block or whatever, we just mix lidocaine and buprenorphine, right?
Yep. All right. So what sort of like adverse effects do we have with these medications? The most common ones are more localized adverse effects. Obviously, the one we worry about are anaphylaxis. But we do have our different types of adverse reactions. Type A reactions are basically really the toxic effect that we expect from the medication. So whatever its effect on the end organ, that's what we call a type A reaction. Type B reaction are the ones we worry about. So those are hypersensitivity reactions, just like our type 1, which is anaphylaxis, which is obviously the most concerning. That one needs immediate epinephrine. They should have like urticaria, swelling, some sort of intraoral swelling, might complain of difficulty breathing. And that's obviously an emergency. We need to get them epinephrine. Typically, we'll see more of like a delayed type reaction or a type 4 reaction, and that one we just treat with fluids, antihistamines, steroids. And these kind of operate on the spectrum too, but these are an emergency if you do have any of those hypersensitivity reactions. Now, if you just have a local reaction, which you might have just like a dermatitis, which you guys are probably covering in your derm lectures, then you can certainly have that as a more common side effect you might see with these medications. All right, so one of the things we have to worry about is toxicity with these medications. And one of the obviously major concerns, we might see that like central nervous system toxicity. Unfortunately for the local anesthetics, the only thing we have to treat this is what we call lipid emulsion therapy. But, if obviously we see these, we need to discontinue the medication, but they can have some prodromal symptoms like that circumaural numbness, tingling, tinnitus. So we need to treat whatever the symptoms are, discontinue the medication. We need to monitor for any arrhythmias too. So sometimes you can get like those supraventricular arrhythmias, like your AFib and flutter. If there's any signs of instability or they're hemodynamically unstable, we need to cardiovert them if we find this. And then obviously, VFib obviously gets defibs. And then you can have seizures with this, which we treat with benzos, just like almost every other seizure. So your benzos. And then they can have a spectrum of the central nervous system toxicity from like, altered level of consciousness to unconsciousness. So it's always something to consider when we're given any medication. So how do we prevent toxicity? So obviously, we don't want to inject these intravascularly, so it's important that we aspirate prior to any injection. And you should be doing that with everything. And you guys know what that means, like you need to pull the plunger back after you insert the needle. And you need to make sure there's no blood returning into the needle. That's what we do for aspiration. And then if you don't have any blood there, then you can inject your lidocaine or whatever medication you're using, bupivacaine. And then we want to avoid any excess dosing. So these are typically for plain lido, it's typically 4 milligrams per kilogram with a max of 300 milligrams. And then if you have epinephrine, it increases it to 7 milligrams per kilogram with a max of 500. We also need to consider, and you'll hear this a lot of times from your nurses, like you want 1% or 2%. So you're just, basically you're looking at the concentration of the lidocaine per milliliter in there. So typically for most procedures you're using this for, it's not a concern, but you do need to think about it when they ask you, hey, which one do you want? If you're, injecting a large area, you need to pay attention to whether you're using the 1 or 2% lidocaine. And like we talked about initially on the slides, lidocaine has that rapid onset, a little bit shorter duration, and then the bupivacaine has that, a little bit longer onset, but a lot longer duration, which is why we like to use that and mix those together. The max for bupivacaine is 2 mg per kg up to 100 milligrams. We don't like to use it in younger children. They have an increased risk of like CNS toxicity with it. That's typically more seen in infants, so we tend to avoid it. But the guidance is don't use it in anybody under 12 still. All right, so what do we do if we end up having some toxicity from this? Obviously, common sense is discontinue the medication, which can be difficult if it's a local injection and you've already injected it. You'll see that we use these for like epidurals as well, and some of our spinal injections. And sometimes those will be a continuous infusion, which is why we say we need to discontinue that immediately if we're giving it. Now they can have central nervous system symptoms, and this can be exacerbated by hypercarbia. So sometimes we can hyperventilate them to decrease that CO2. And then if we have any seizures, benzo is going to be our best treatment for that. And then obviously hypotension, give them some fluids. And then all the arrhythmias we just treat for the ACLS algorithm. One of the concerns, and this isn't typically with local anesthetics, this is more with like your succinylcholine and gases. You can get malignant hyperthermia, which is a rare inherited condition. Most patients actually don't know they have it before you give them any of these medications, but it results in like a hypermetabolism. So they'll get fever, like muscle rigidity, they're going to get hyperkalemia. It's an emergency, and their fevers are usually pretty significant of that hyperthermia. So we need to treat with rapid cooling, bicarb, and the only reversal agent we have for it right now is dantrolene, is the medication we give for that. And this, a lot of ways we avoid this is, anesthesia likes to mix a lot of different agents to prevent toxicity from any one agent. So we're usually using a mixture of we'll induce them with some sort of gas, and then we'll use succinylcholine for the intubation. And a lot of times when we mix these, we can avoid these effects with one medication. All right, so how do we do this? For all these minor procedures or minor surgeries, laceration repairs, we usually use the local anesthetic, obviously avoid it in infected areas. We usually use a long, thin needle, typically like a 25 or 27 gauge, works really well. We need to insert it all the way through the area, and then to avoid multiple punctures, we aspirate, and then we don't get any blood, and we inject as we remove the needle. So you can cover most of the wound. Sometimes it's good form not to remove your needle completely and turn the direction of it, and you put it in there, you can usually get both sides of the wound as you come through. You can do that with one needle stick, and just it's a good good form to do that instead of sticking them like 5 times in that area. Sometimes it is required because you don't get good anesthesia, so you may have to stick them multiple times and come from different directions of the wound. But the sequence of the analgesia is vasodilation, followed by loss of pain, pressure, and then motor function. And typically you give it a couple minutes after your injection, you recheck the area. You can use a needle and just give them a little poke. Do you feel that? Do you feel pain, pressure, anything? Typically they won't feel anything. If they continue to have sensation, then you can inject a little bit more. You just have to pay attention to how much you're giving, and you're not going over that max for the medication. All right, why do we add epi? For long duration, yeah. But also, you know, the vasoconstriction helps with bleeding too, so it's usually, if it's an area we can use epinephrine in it, we will. All right, so sometimes that area we're going to operate on or do the procedure on, sometimes it can be too large of an area for local anesthesia, so we look at doing like our regional nerve blocks or peripheral blocks. Most commonly, you guys will use a digital block. So as you can see where those nerves run on the hands and foot, you're going to usually inject like they're doing on that picture there where you see the needle, so you want to get the nerves that run, you know, on the inferior and superior portion. So you'll usually insert on the top, go all the way down, hopefully don't go through the bottom of their digit, but you know, it happens. And then you inject, and as you remove the needle, you're injecting. And a lot of times you can inject as you're going all the way down to the sole of the foot, come back up. You don't have to pull the needle out, you can come across and get more of those nerves, and then you do it on the other side. Sometimes it can take, you know, a couple injections before you get great anesthesia or pain relief where you can actually do a procedure, but you guys will do a lot of digital blocks. You'll remove a lot of toenails, things like that, ingrown toenails. This is a common procedure you guys are going to be doing. And yeah, we obviously want to make sure aseptic technique. We don't want to cause any like joint infections or anything like that. And then you can see the rib. They use it for rib blocks a lot too. And you can see where the that nerve is. And that's why we say when we're doing like a needle chest decompression, why we don't want to go over the top of the rib, because we can hit that neurovascular bundle. But that's where it's located if we're trying to get any sort of regional nerve block in that area to help with pain control. And that'll be, we'll commonly use that, especially with like rib fractures, multiple rib fractures. So it's a good procedure for that. I know you guys think like, oh my God, we gotta know all that. No, you don't have to memorize all these. Just understand that there are regional nerves that you can block to get anesthesia, and then you don't have to inject that whole wound, or you don't have to provide as much local anesthesia. So we do use regional blocks a lot. Like I said, most frequently in your digital blocks, but we'll use them. Sometimes we'll block the whole hand. We'll do it at the wrist or the whole extremity if need be. But typically those larger distribution blocks, you'll have to get more training, and you're not going to be credentialed in those large regional areas other than the digital block typically, unless you go for some more training. And most of the larger ones, we use ultrasound guidance for those. All right, so central nerve block. So we have our spinal blocks. This is a subarachnoid block, which we typically call a spinal block versus an epidural. So there is a difference, as you can see with the, not insulting his intelligence, but one goes in epidural space, one goes actually into the cerebrospinal fluid. So you're going to have different analgesia and anesthesia effects from this. And one of them, since the subarachnoid block goes into the CSF, you get a very common complication from it, which is a post-spinal headache. So, the nice thing about the spinal block is it blocks everything, sympathetic, sensory, and motor function. So it is great for like lower abdominal, lower extremity procedures, and then GYM procedures as well. Typically, this is gonna be managed by your anesthesia service. You will see these headaches a lot in your clinics, or especially in the ER, we see these post-spinal headaches. So we usually start with conservative treatment for these when they present with this. And a lot of times conservative treatment fails and we have to do what we call a blood patch or an epidural blood patch. So basically, we have a CSF leak from that spinal block that they did. So we basically have to use some of their blood, so it's like autologous blood, and we'll inject it into that area to help stop the leak or plug the leak of CSF. So that's very common. If they fail like conservative treatment with just fluids, Tylenol, then we typically have to call anesthesia to perform that blood patch on them. All right, then we have our epidural anesthesia. So this one blocks sensory, not necessarily motor function. This one also works well for rib fractures. And this one so when this one doesn't go into the CSF, so you don't have to worry about that CSF leak. Basically, you're entering up until the subdural space, and you're not puncturing that, so we don't have as many of the complications like we see with that post-spinal headache there. But this one usually has the catheter taped on the skin, and then it requires a continuous infusion in larger volumes of anesthetic. Like I said, this is one where you might be giving that large amount of your lidocaine or bupivacaine, so you need to think about your max dose. Typically, this is going to be done by anesthesia as well. You guys aren't typically doing these. You will, you'll watch them and assist in them. They might let you do them during your phase 2, but you're not going to be credentialed for this unless you go through more specialty training. All right, here's the position. So the spinal cord typically ends at like L1, or the conus medullaris is at L1. In adults, it's L3 in kids. So the position we like to use, a good guide is like you have your PSIS, and typically if you just go in between the inner space between the PSIS, you can see where they kind of are there. You're usually at like L3, L4, and that's usually the safest place. You find the inner space, and then you inject into there, or insert your needle into there. It's the same position we use for doing a lumbar puncture as well. But as you can see from the dermatomes there, where we're going to get that anesthesia relief, depending on what level we're going to. And then here's just a great A&P animation here of where those different blocks are going. So obviously your epidurals and epidural space, and the spinal's going into the CSF. All right. What do we think? Yeah, so it's going to be 4. That one's typically, like I said, L1 is where the ends in adults, typically L3 in infants. All right, what kind of complications can we have from this? So we certainly can get like a neurogenic shock. Sometimes it requires vasopressors. So depending on what type of patient it is, we use a lot of different pressures for different things. In pregos, we like to use like phenylephrine. Most of the time we use norepinephrine most commonly, but we usually start with IV fluids. If they don't respond to that, we'll move on to pressors. And then we also have to worry about where we're doing that nerve block at. So if it's like a high spinal block, we got to worry about like bradycardia, respiratory distress, hypotension. We may have some sort of arm numbness depending on how high we're going, so they could have arm tingling. And then we always got to worry about cauda syndrome as well. So that's why we try to use that safe space, and we're hopefully not going up into the spinal cord, which is, hopefully we can go low enough, but sometimes we can get a hematoma there, so we'll get some bleeding, and that can cause cauda equina syndrome, which, do we all remember what the symptoms of that are? Yeah, like saddle anesthesia. The most common symptoms probably like urinary retention, so that's always a good question. Any sort of like change in bowel bladder function. Sometimes we'll do a post-void residual with our ultrasound to check if there's any sort of urinary retention. Alright, so yeah. Obviously, depending on where the block is, the most common complication is going to be urinary retention. And typically, we're doing it for those like lower extremity or GU procedures. Obviously, used during delivery as well. So, you might see this, with the obstetric patients. And like I said, you need to get a post-void residual or just look at the bladder, usually with an ultrasound. They actually have more readily available methods as well. So since ultrasound kind of takes some training, we have like little scanners that look like your little vital sign machine, and you can use that as well to tell you if they have any urinary retention. So we do have other methods that non-providers can use for these. And like I said, we got to worry about that spinal headache and that CSF leak. And typically they'll have it worse with postural changes, so whether they're laying or sitting, sometimes it'll improve their symptoms with, and that's another indication like, okay, we probably have a CSF leak. We might need a blood patch, but we can also treat it with fluids, caffeine, Tylenol, and then we can do that blood patch if those methods fail. And then obviously the epidural hematoma, so that's going to cause your cauda equina type symptoms. Typically, we avoid doing these sorts of things if they're on any anticoagulation. So, hopefully we're not doing it on those patients, but sometimes, they may have discontinued it and we did the procedure, and we have to, consider this when we're evaluating them, especially in that post-op period when we're rounding on our patients. So we need to check their neurologic function. All right, what are we doing for this one? We didn't talk about pressors much, did we? Who says we should just reassure the patient? I mean, honestly, what I would definitely do number one first, but I would make it not noticeable. Yeah, it's usually poor form to get, vomit all over you. This one's administer phenylephrine. Likely we would start with an IV bolus of fluids on this patient. But, phenylephrine is the treatment of choice, especially if we need a pressor. And it works great during pregnancy as well. All right, conscious sedation. So this is something we do quite frequently, and this is like a spectrum of anesthesia and analgesia that we try to give our patients, depending on what the procedure is. So we typically want a minimally depressed level of consciousness. If we can get some amnesia, great. So they don't remember the procedure, that's even better. But what we need to be concerned about is the dose we're giving and whether they can protect their airways still. So we do have levels of conscious sedation, which we're not gonna, we don't need to worry about the different levels right now. But just understand it is a spectrum. And sometimes we do need these for procedures, especially with if we're reducing shoulders commonly. You'll sometimes need some sort of conscious sedation to overcome those muscles of the shoulder. So this is something we commonly do you do have to be credentialed in it, so you can't just go wild with these. The concern with this is we have to have like a one-to-one monitoring when we do any conscious sedation in the hospital. And we'll have, every facility has procedures for it. So sometimes one of the issues is like, you don't have the staff to be able to do a conscious sedation on a patient. So sometimes you have to look at your staffing level too, and whether you need to, refer this patient to the operating room versus whether you have enough staff to do it yourself. We find this very commonly in the ER, we don't have enough staff or nursing staff to be able to do a conscious sedation. Because they have to be continuously monitored with vital signs the entire time. They have to have a one-to-one ratio with the nurse, and then you have to have somebody there monitoring the drugs that you gave as well. As you can see on there, propofol, it's like a milky looking medication. Works very well for conscious sedation, but once again, you need all of those resources there. And then they all have their side effects as well. Ketamine is probably the most commonly used and the most stable side effect profile. However, we still use etomidate very frequently. The medical equipment sets in the Army still come with etomidate. Ketamine's controlled, so sometimes you have to use, the only thing you have. So it's always something to consider. And then you can have, significant side effects from some of these, especially like your propofol. So you always need to be concerned about their airway, hypertension. So you got to be careful what patient you're giving it to. They do have abuse potential as well. I think propofol is what killed Michael Jackson, which is kind of wild that he was using that for like recreational purposes, but it can be used for that. So it's something to think about. All right, so like I said, your hospital will have an SOP, but before you do any even conscious sedation, even if it's not a surgery, you need to consider when was the last meal they had. You have to worry about aspiration still. You always want to look at the ASA category of that patient as well. And then do we have the dedicated staff for it? You should probably have your crash cart there. Some facilities will require it, some won't. We typically move them into like a recess room a lot of times when we do these. If we don't have one, I always move the crash cart there to ward off bad spirits, because then, you have it and hopefully you don't need it versus the opposite. So yeah, you gotta have oxygen available. Typically we'll have them on a nasal cannula when we do a conscious sedation. And then you need all your airway adjuncts, ACLS drugs, suction. It's always safe to have a backup suction too for when one fails. All right, so there's our Mallampati scores. It's always something we need to look at prior to doing any of these procedures as well. So even if we're doing a conscious sedation, it's always good to assess this, or should be required to assess this. Just because if it goes south and you got to intubate them, you want to know what you're getting into. And it makes you think twice. If it's a difficult airway, then you might want to consider, hey, we can do this conscious sedation, but maybe I need anesthesia here with me if it's going to be a little bit more of a difficult airway. So obviously you want to assess them like we talked about in the pre-op phase, or pre-op stages. So you want to know what kind of medications they're on. Are they taking any sort of anticoagulants? Obviously allergies, medical history. And then, just like in the first lecture, do we need to get, or the first block, do we need an EKG prior? Do they have any history of any heart disease? Do they need a chest x-ray or referral to the pulmonologist prior to it? Then we need to consider like those ACEs and ARBs as well, if they're taking antihypertensive medications, worried about that hypotension when we induce them for anesthesia. So, what is our goal? Obviously, we want some sort of reversible state of CNS depression so we can perform these procedures on them, and it is a spectrum, so we try to use a balanced approach. So we'll typically use, if we have gases, which are becoming more common now, like even in the emergency rooms, we're using gases just because it's quick on, quick off. It provides very great analgesia and anesthesia. So those are like more common options we're looking at now to use versus just giving them medications. And it's sometimes easier to manage. We have a lot of medication shortages nowadays too. So like we had ketamine shortage for a long time. So we could only use it for like certain pediatric procedures. And we weren't allowed to use it for like pain control or anything like that. So we have to consider those too, which is why gas is becoming more frequent. And then we have our like benefits of anesthesia. So obviously, you know, sedation, we reduce anxiety, we can create amnesia so they don't remember the event. This is good for like when you're thinking about those battlefield casualties or combat casualty care. There are a lot of studies that show if you use ketamine and provide that amnesia, a lot of times it can prevent PTSD as well. So it is something to consider even in your like combat casualty care environment too. All right, so here's our stages of anesthesia. So induction, typically from the time we give the medication to the onset. And it depends on what we're giving and how fast it works. Like our neuromuscular blockers usually work relatively quickly, typically under a minute. And then we gotta look at what we use for maintenance. So even once, like especially with like RSI or rapid sequence innovation, just innovating them and getting them inducted is just the starting point. So we have to think about what am I gonna use for maintenance now? This is something to consider, especially if you're in like a roll one or aid station. A lot of times you guys may, you know, your medics may not have experience, or you may not have experience of actually running a drip on a patient to continue that anesthesia on them. So it's always something to consider, even in your like roll ones and that you guys are trained on it. And then we obviously have the recovery or emergence from it. So this is usually like time until we send them to the PACU or until we finish our procedure and they gain their reflexes back, they're able to protect their airway, and then they can go to recovery. All right. And like we talked about, or like I just said, for our maintenance, like our, you know, we have our induction, but then we have to maintain everything throughout whatever the procedure we're doing. So a lot of times with general anesthesia, we're gonna, you know, those patients aren't gonna be able to protect their airways, so we're gonna have to intubate them. They're gonna usually be on some sort of continuous fluids, and then they have to be monitored with their vital signs the whole time. We also have to think about if you're paralyzing them, you know, and you have to protect their eyes, so if you leave their eye open, you run a risk of obviously a dry eye, but you also run a risk of some sort of, anything could cause some sort of abrasion or laceration. So you always have to consider that as well. Sometimes we'll tape the eyes shut, and then we need to prevent hypothermia. And then what do we do to mitigate this? So like I said, well, everywhere has a policy, procedures. We have to have continuous monitoring. If they're intubated or they're under general anesthesia, typically anesthesia is there for continuous monitoring and using those medications appropriately and the gases so that we keep them under. And then we obviously got to worry about aspiration. That's why we place them NPO. We may use an antacid like a PPI prior to the procedure. We can provide cricoid pressure so we're not insufflating the abdomen. Then we need to think about like any nerve injuries if they're going to be paralyzed. So we like to pad those pressure points, you know, not hyperextend any of those joints, which can happen, and then lubricate, tape the eyes closed. And the recovery rooms, that's what we call the PACU, the post-anesthesia care unit. And this is, once we meet all these goals, typically they can go home. So they're obviously stable, they're ambulatory, fully responsive, they're alert and oriented. A lot of times we'll have to provide them with some sort of oral intake and make sure they can actually maintain their secretions, they can eat, drink, hopefully void. And that's typically what we use to basically say that they have met the PACU criteria, and we can probably send them home as long as they're stable. We usually always have them with an adult chaperone, so especially outpatient procedures, that's why we tell them they shouldn't drive there themselves, they need somebody to actually take them home after the procedure. And if we can't meet these, then we need to keep them in the hospital until it's met. All right. So we talked about our anesthetic options and adverse effects. What we do for these, what questions do you guys have? No? Come on, at least have one question. All right, you guys can take a 10-minute break.